our next topic. This is going to be a topic which most of us who are aspiring or currently doing EUS and are usually in the dilemma that is there or is there not a stone in this common bile duct. And often we find it on radiology, we don't see it on ERCP, and vice versa. So I would like to call Professor Dr. Abbas Ali to talk about do we really need MRCP for diagnosing a CBD stone? Dr. Abbas Ali is an associate professor of medicine and gastroenterology at SIUT Karachi. He graduated from Dow Medical College and holds a fellowship and membership of Colleges of Physicians and Surgeons Pakistan, as well as Masters of American College of Gastroenterology. Sir, please, can you please join us on stage? Thank you very much.
Thank you, Dr. Yasser. First of all, I would like to thank the PSH team for allowing me to speak on this platform. And I am Dr. Abbas Ali from SIUT. So the topic is actually a question. Do we still need MRCP for the diagnosis of CBD stone anymore? So first, let's have a look at the American Society of Gastrointestinal Endoscopy criteria for the prediction of stones. You can see that if the patient has a stone in the bile duct, or if there is an ascending cholangitis, or if the bile duct is only dilated and the bilirubin is more than 4, it is a high probability case, and the patient can be offered ERCP straight away. However, if there is a dilated common bile duct but the bilirubin is not raised, in these cases it is the intermediate probability, and this is the one case in which either the EUS or the MRCP is required. The main competitor of MRCP here is the EUS. So this is the comparison of the various imaging modalities. You can see that MRCP and EUS have very good sensitivity and specificity, and it is quite close to the ERCP, which is considered the gold standard. The information contained has been taken from Schlesinger, the 11th edition. So coming back to our question, do we still need MRCP for the diagnosis of CBD stone? First, let's talk about our local experience. So this is the equipment and the technique that we have been using. This is for the learners. You can see that this is the radial scope, which gives a 360-degree view, and this is how it appears. So you can see that this is the entire is a CBD, and this is the distal part of the CBD, which is joining with the PD to enter into the ampulla. It is important to see the very distal part of CBD also to make a diagnosis. And this is the linear EUS, and this is how it is seen from the bulb. You can see that the bottom structure is the portal vein and the top one is the CBD. It is being traced down to its distal most area where it is joining the pancreatic duct and opening into the ampulla. So this is the first case. This is of a 25-year-old lady who had cholestatic LFTs. The MRCP showed up the presence of a CBD stone as shown, and ERCP was planned, but the procedure was subsequently deferred as the LFTs improved. So assuming that the assuming that the stone had actually passed away, we did an EUS just before the discharge, and this is what we saw. You can see that this is the CBD and this is the stone. It is casting a strong acoustic shadow. So what we see here is that the EUS offers a very good real-time view, because the EUS scope is next to the CBD in the duodenum. There are no interfering gases or abdominal wall, etc. So this is the first advantage. Whereas MRCP shows a static images, EUS shows real time and dynamic view. This is the second case. This is of a 36-year-old lady who presented with D-range LFTs. The MRCP showed CBD stone. ERCP was advised, but the patient left against medical advice. She was readmitted 3 weeks later, and this time we did an EUS. You can see here that whereas the MRCP was showing a single stone, there is not a single stone, there are actually multiple. And how do we know? Each of them is casting a different acoustic shadow. So you can see there are 3 stones in fact, and all of them are casting their different acoustic shadows. So this is the third case of a 42 years old lady who presented with cholangitis, and the MRCP suggested that there is probably a soft tissue lesion in the distal CBD. ERCP was planned. However, the cannulation failed, so the patient was advised to undergo PTBD. And this is a PTC cholangiogram. You can see that there is a obstruction at the distal level. The guide wire was passed and a PTBD drain was then placed. Now we did an EUS with the intent that probably there is some pathology in the periampullary area, and you can see that this is the PTBD drain at the top in the CBD, and while we traced it down towards the distal part, we were surprised to see that there was an acoustic shadow. In fact, two acoustic shadows and a stone. So this is the stone and this is the strong acoustic, in fact two shadows. And this is the PTBD drain that you can see. So in this case, EUS clarifies that it's not a mass lesion, but it is an impacted stone. You can see the two different shadows. This is case number 4. This is of a 40 years old man who presented with derailed LFTs. Extensive workup was unrevealing. The MRCP appeared normal, and the EUS was then planned to look for any periampullary pathology. This is the video. You can see this is the CBD as it is appearing from the radial EUS. This is dilated. It is being measured. And this is the distal part. You can see that there is some echogenic material in the distal area. This one, which is surprisingly not casting an acoustic shadow. So the EUS can demonstrate small sludge balls, which might sometimes be missed by the MRCP. This is the 5th case. This is of a 32 years old male who presented with repeated episodes of mild acute pancreatitis, and the LFTs were normal, the MRCP was normal, and his EUS was planned to rule out any periampullary pathology. Now you can see that the CBD is being traced. This is the linear EUS. This is being traced down to the distal end. Now we see it again. You can see that in the distal part, there is some tiny stone that was missed by the MRCP. This is the importance of EUS. You can see the very distal most part of the CBD. So ERCP cholangiogram even failed to show, but when the balloon sweep was done, a small tiny sludge or maybe the gravel was extracted out. This is another case, and here again you can see the scale given about 10 millimeters, and the size of the echogenic material is so small, so the EUS can detect the microlithiasis as well. And then there is another case in which we did the radial EUS, and you can see that there are tiny acoustic shadows casted by the tiny stones. So this is gravel, and this is a size of only 1 millimeter probably. So the advantage EUS offers is that it can identify microlithiasis that the MRCP might miss. This is another case of a 60 years old lady with vague right upper quadrant abdominal pain for the last 2 years. Her LFT showed only a raised gamma GT. Ultrasound abdomen showed cholelithiasis. CBD was normal. EUS was then planned for this raised gamma GT. You can see in the video that these are the gallstones. And this is some structure in the distal CBD. It is some linear structure moving from one wall to another. We were just wondering what this could be. Could it be some linear stone or a septum or a worm? We were confused. We did not know what this was. So we needed some other investigation to confirm what this was. So we headed towards MRCP. This is the MRCP, and these are the rotational images. You can see that there is another duct that is lying beside the CBD. It is moving upwards. If you trace it, it is going and joining the cystic duct above and then the gallbladder. So what we saw here was that You need a rotational image in the form of MRCP, which can clarify what we were seeing on which we could not see on EUS. So you can see this is the three-dimensional image. This is the very low-lying cystic duct, which is going and joining into the distal CBD. So what we were confused about was actually a partition in between these things. This is the CBD, and the other one is the very low-lying cystic duct. This is another case of a 52-year-old lady who has history of peptic ulcer disease for the last 15 years. Her alkaline and phosphatase and gamma GT was raised. We were thinking that probably she might have a stone, but the transabdominal ultrasound was unrevealing because of the excessive bowel gases. We decided to do an EUS. However, when we went inside, we saw that there was a benign peptic pyloric stenosis. The scope could not be negotiated beyond, so we just started to see from the stomach. And you see, and this is the porta hepatis area. Above is the liver. The top structure is the portal vein, which is showing the Doppler flow, and beneath it or deeper to it is the CBD, which is dilated. You can see how dilated it is. From the scale, you can roughly get an idea. It's more than 6 mm. And when we traced the CBD down, we saw that there was a hyperechoic signal that was casting an acoustic shadow. So this made it clear that probably there was a stone inside. However, we could not see the distal part of the CBD. We needed help. So we went for MRCP and we found that there was another stone in the distal CBD. So here, this indicates the importance of MRCP, that when there is an altered anatomy, MRCP is more helpful. So this is actually what we saw. Now, so far we have talked about our local experience. Let's talk about the international evidence. Earlier years, it was the MRCP use was not, the EUS use was not that common. MRCP was being used more. And one of the studies concludes, it's a French study, it concludes that since MRCP is relatively non-invasive, it's non-invasive and it is equally sensitive, so MRCP should be the preferred choice. However, with the later years, we saw that EUS is equal to MRCP, and in the recent years, we can see that EUS has become even more superior to MRCP as far as the sensitivity and the diagnostic accuracy is concerned, and due to its ability to identify small stones. So coming back to our question, we feel that we should go for the EUS, particularly if the EUS equipment and expertise is available. And if the MRCP is not possible, for example, in case of cardiac pacemakers, implants, claustrophobia, and since MRCP is very sensitive to motion artifacts, a patient is needed to hold his breath. If a demented patient with 80 years of age comes and if he starts to breathe without making his body still, it will create horrible images and it's a useless test. So in that case, EUS might be helpful. It is very close to the CBD. So EUS has a low cost. It has a higher sensitivity and accuracy because of its proximity to the CBD, high resolution and real-time view. Also, it can detect small stones because of its unique ability to demonstrate the caustic shadow, and it can also pick up the echogenic material which is not casting a caustic shadow to the size of as low as less than 5 mm. It can allow therapeutic ERCP in the same session, and it can, if there is no stone, it can help avoid an ERCP. As Peter Cotton says that ERCP is most dangerous for patients who need it the least. Besides, EUS can also help you in identifying the periampullary pathology and hence also biopsy it, which the MRCP can't, and also the learning curve is short. However, let's not belittle the value of MRCP. MRCP is a very sensitive, non-invasive test, and when the doubt remains that we saw in one of our cases, we need MRCP. Also, in cases of altered anatomy where there is the entire CBD cannot be visualized, the MRCP will help. Also, if the EUS expertise and equipment is not available, then MRCP might help. Thank you so much for your attention.